Thanks to an excellent panel. Maybe before responding to the panel, I 3 years ago spent a sabbatical in Dublin and was able to carry out a few surveys, primarily with physicians. Ireland only introduced a program to address the problem of elder abuse in 2007. So this survey actually took place in 2009. But neglect was the most common type of abuse and neglect reported. For some reason, I tried to access the self-reporting or self-reported or self-neglect data and still haven't been able to access that. There is no mandatory reporting, and the substantiation rate was 23%, which is troublesome. A lot of cases were left open. If I can have the, even I can do that. And then I surveyed geriatricians in Ireland and Scotland with regard to self-neglect. We got a 40% response rate. Personal neglect was the feature that they encountered most frequently. And I suppose one of the frustrations that they noted was the refusal of services. Non-compliance was a huge issue, and I'll mention something about that a little later. But they also noted that in these cases, they estimated maybe 40% there was an element of abuse, and probably not surprising. I mean, this is a very vulnerable group who self-neglect. And noted also that males were more frequently affected than females. I surveyed 800 general practitioners regarding abuse and neglect. 25% response rate, and self-neglect, again, was the most common type that they encountered. I suppose a contrast with this country, general practitioners still do home visits, and that was the usual site of discovery. Interestingly enough, 70% felt that after some intervention that the situation for the victim had been improved. This is in contrast with another study that I'll show you. 14% actually were threatened by a caregiver. So then I surveyed old age psychiatrists in Ireland, and you realize it's a small place. There are only 22 of them. Clearly have to be overwhelmed. But we got a good response rate. 92% had encountered a case in the past year. 59% felt after their intervention that the outcome for the victim was unsatisfactory. And 72% felt it was unsatisfactory for them. So this may be a more cynical, depressed group. And identified dementia as being the most common cause of self-neglect. In response to our panel, there's very little to add. My bias is there's a societal neglect of the most vulnerable elderly. And where is AARP? As a geriatrician, geriatrics is really an orphan specialty. We struggle to recruit people, and it defies logic because clearly this is the growth area, lots of opportunities, and the highest or second highest, one or two, satisfaction with work in contrast with other medical specialties. And also here, specifically here to engage in dealing with a problem that has significant mortality, certainly compromises quality of life, and particularly at the end of life where there's little opportunity to recover. It's too late. I think Dr. Fulmer achieved her goal. Really appreciated her review of studies in chronologic order, highlighted the scope of research, the limitations of the studies, and the lack of funding, and also the complexity of engaging in research in this area, and what a deterrent that has to be for young researchers. So my sense is, yeah, we need more funding, but we need more mentors as well to help with this. The studies certainly restated what we know as risk factors and cognition or declining cognition, poor health, age, social isolation, wrong, race and income. Those seem to be factors or features common to most studies. And also commented on a few other studies that we heard as well this morning, that this is really a worldwide phenomenon. So it's not unique to the US. I think the last thing I would say about Dr. Fulmer, she has served as an untiring advocate for increased interest and funding in this area, and should be complimented for that, Terry. Dr. Dyer, I think, has created a state-of-the-art program in Houston. It's not multidisciplinary, it's interdisciplinary, and I suspect a very egalitarian environment in which to function in. So, I mean, they've assembled, or she has, what I feel are all the elements necessary to evaluate and intervene in a coordinated fashion with cases of neglect and self-neglect. And I thought, maybe I'm characterizing this incorrectly as an algorithm, but for those that have a really cynical view about self-neglect, it's futile, people refuse services, what can you do? She highlighted opportunities on both sides. So there's intrinsic, unique to the victim, and extrinsic, unique to the environment. So there are opportunities to intervene and improve the situation. And I think reinforcing this is the demonstration of the superiority of that model versus usual care. I wish we can duplicate this in many other communities. Vitamin D, which is the vitamin du jour, and seems to deficiencies in vitamin D seem to be extremely common, and was able to demonstrate improvement with a relatively inexpensive, benign intervention. The various instruments that she has developed, including the CARE tool and self-neglect severity scale, are hopefully tools that can be are used by a much broader group of practitioners. Finally, the intervention with medication is a huge issue. Somebody mentioned that this morning, the issue with polypharmacy, and yeah, it is a huge issue, something we deal with, and sometimes non-compliance can be life-saving. Our record is somebody who is on 34 medications, and we're not going for anything higher. And it's much more difficult to discontinue a medication than it is to start it. So huge issue, and these people do need supervision. Kathleen, Quinn, the wonderful work of NAPSA, a maligned group of people, and I applaud you for what you do. I'm most impressed. And her presentation highlighted some of the issues. How can we ever determine incidence and prevalence studies when there's so much variation among states? It did again verify that self-neglect is the most common type reported. And just two last observations. I mean, this capacity determination is an absolutely huge issue. Who does it? I mean, is it something that's done with a a short mental status or a few questions, because the consequences are so significant. I mean, I wonder if it's tempting, and I'm not accusing anybody, if it's tempting at times to say somebody does have the capacity, so therefore, they're telling us not to intervene, and hopefully that doesn't happen. Equally shocked at the lack of preparation of the APS workers. I mean, I think that's a disgrace. I've no idea what the competencies are, qualifications on entry, but something that has to be addressed and clearly needs more funding. So I think our panel were exceptional, and I thank them for that. Thank you.
We might have lost our time for questions, but we'll have.
No, thank you very much for the distinguished panel. I think we learned so much from you today. And I want to make a little announcement because we want to make sure we have enough time for questions. We're gonna audaciously decide to skip the break, and you can throw eggs at me for that, because we want to, and if you need to use washrooms and snacks, then please help yourself. One of the questions that's really burning my retina is how do we determine the continuity of self-neglect and neglect? Is it just because someone's living by themselves and their family live upstairs? When at the point do we determine that there's a caregiving responsibility in place? I would love to hear each of your thoughts on not necessarily the theoreticals, and because we can always say, this, if you spend 20 hours a week with your mother, then you're a caregiver whether you live in the house or not. Or is it culturally a caregiving responsibility, as it is in Chinese culture, many other cultures as well, that there's unspoken expectation for caregiving? It doesn't matter whether you're in the same house or you're in a different continent, that you're expected to provide that. I struggle with that, and I know a lot of folks are, from research to practice to determination from an APS perspective. I would love to hear your thoughts on that.
We did a survey of all 30 APS workers in Houston, which we published in Gene many years ago, and it was a qualitative study, and really the APS workers all told us it was whether or not there was a caregiver in the house, because clinically there's really very little difference.
I agree with you, and let me say, for the purpose of this forum today, in order for us to build the evidence, we have to make a definition and use it. And here's what I mean. So in our study, I worked with Barry Gerlin at Columbia University, and we made a decision that if you had a caregiver, if you had meaningful contact with somebody for more than 20 hours a week, and that was that. And so you could define that, you could defend that, and I think that we're going to, as cluster researchers, we're just going to have to say, let's all go with this for a while and see what we can come up with, so that we begin to get some streamlining of what we want to do. It's for us to define it. It's for us to define it.
I can just speak to what we did in Illinois, because I don't know nationally. Each state has different definitions, of course, for what constitutes self-neglect, neglect by caregiver. In Illinois, we said that if somebody undertakes to provide care to the older person, then they can't stop providing that care in an irresponsible manner. So if you were taking dinner to your mother every night and then you just left on vacation and didn't provide the dinner, then that was an evidence of neglect. Now, I have to say, probably 80% of the cases, or 90% of the cases maybe, I don't know exactly, but a lot of the cases that were investigated, it was the alcoholic son living at home who was, moved in theoretically to care for the mother. I mean, it was pretty obvious that person was saying they were a caregiver, or the other family said they were caregivers, and they were not at all adequate.
If I might, I wonder what gets you off the hook. If you're a child and there's a dependent parent, does moving away or being away then not obligate you? Also, I think what I've witnessed is families designating somebody as a caregiver, and oftentimes it's not necessarily the person that had the best relationship with the parent. That's a whole other issue.
I'd just again like to make a plug for, and to move the field forward, to go ahead, have a conference call, make some decisions about 2 or 3 strategies, and then see what we could learn from them so that we can get past this question.
Certainly to go ahead, I agree. You got to have some consistent definitions, whether or not everybody agrees, because otherwise you're not talking to each other. My question is about self-neglect and the proportion that are who have dementia, the proportion who have depression, the proportion who are cognitively with it. And I didn't see any, because of those, dementia right now we can't do much about. Depression we can, though I'd be reluctant to add the 35th drug. But depression is a treatable disease in the elderly, and if we could actually get those people to accept treatment, might decrease the self-neglect. So of that self-neglect pie, how much fall into those categories, and is there a chance that would help us at least attack some of it?
Sure. About 30, 40%, dementia 30, 40%, depression, depending on the studies you looked at. I've seen some studies that had as high as 60% for elder self-neglect. But there have been no intervention studies in depression, which would be a really good place to start.
Hi, Evelyn Tomaszewski from the National Association of Social Workers, a voice from over here. I'm a member of the forum. I was listening to, thank you again, it was all very informative. As I was hearing the statistics on non-adherence and the ideas of neglect and abuse and how provider resources, I was thinking about the population who are living with HIV or AIDS and aging out, sound like they're leaving someplace. But as that community ages, there's a parallel track of people who are growing older with chronic illnesses, with mental health issues, with substance use issues. So I'm curious in terms of how we might inform those 2 silos, or those many silos, that there's data and research, for example, in the HIV field that may well inform the adherence research in working with older adults, and what might be the information that can inform those working in other fields. So I don't know if I'm making a statement or asking a question, but I think that there's some ways we could really learn across issues.
With the electronic health record, that should be a very easy thing to look at in the HIV treatment centers. And Houston, we have one of the largest in the country, and that's a great idea to go take a look at those. Now, there'll be smaller numbers, obviously, elderly in HIV, maybe 55 and above, but still, that's an excellent idea. So.
I would go back to I think that is an excellent idea, and I'd go back to one of the constructs I mentioned earlier, and that's intentionality. It turns out that of all the prescriptions ever written, only half are ever filled. Of those filled, only 20% are ever taken. Something like the numbers are dismal across all diseases. But if somebody's not taking their meds because they don't want to and they're competent, or somebody is taking them, so again, it's that precision that's going to be so useful for us to move the dialogue.
I do. I think it's a really opportunity to really to share the resources as these 2 seemingly separate communities are moving forward and will be the same person.
Mark Lax, New York. I just have 2 very striking things 2 striking facts that were presented repeatedly in the research. On the one hand, in adult protective service land, 3/4 or thereabouts of cases are neglect, okay? And in every prevalence study, okay, that's done through telephone surveys, IADL use, using the telephone being an IADL, that's the lowest subtype of elder abuse. So that is the big chasm between science and service here. And while I don't think we need any more prevalence studies of elder abuse generically, I think we need really good methodologic studies of neglect. And I'm wondering if any of you could comment on any ideas you might have about how we get to these people. Because I've been racking my brain. It's easy if you get someone on the telephone, they've got a mini mental that's probably okay. It may not be perfect, but the people that you're trying to get to and you're trying to measure, because this is really, you saw Jinshi's iceberg slide. This is the iceberg. So Can any of you talk about novel methodologies one might use to truly get at the prevalence of neglect for these people who are hidden in adult daycare centers, in home caregiving situations? Any light you could shed on that?
Well, the reason why we developed the self-neglect severity scale is because, as clinicians, just talking to the patient, seeing them in the clinic, we're never going to be able to pick up on a lot of the self-neglect. And so, the idea could be to get community workers, first-line responders, home health agencies to do some screening in the communities using this simple tool like that to try to pick up on the prevalence. We've also got a geospatial scientists that started to work with us with the University of Houston and try to look at some mapping where the reports come from and then go into those neighborhoods and do some door-to-door. I mean, it's going to be, blood and sweat to get those. It won't be a clean database study.
Right. No, I think technology may be the
Are you
answer.
talking about neglect or self-neglect?
I'm talking about neglect.
Okay. So pretty much you have a pretty good shot if you start in points of contact with physicians, and that regardless of setting, we know that you can screen for neglect in emergency rooms and busy primary care clinics, and then we're going to have to just keep to the notion that we're going to understand the construct of neglect as separate and distinct from self-neglect. And so that means we're going to have to decide what a caregiving relationship is in that particular study and then figure out what goes on with it. You can't do it by a random.
Yeah, but Terry, the issue is representative samples. So when Ron and I do a prevalence study, and I'll just 30 seconds on a methodologic point,
right,
we get census tracts of telephone numbers, and this is a representative sample of New York State. But those people we're talking about are systematically excluded because of their cognitive innate. This goes back to Kathy's comment at the beginning. This is the gorilla in the room in all forms of elder abuse, and in elder neglect, this is the 8,000-pound gorilla.
Yeah.
And we need, and I think some of the sort of the Google mapping or the geospatial stuff, we're really going to need some truly novel, high-risk, high-reward methodology to get at a community-based prevalence estimate. If we're not going to use these convenience samples from my clinic, you got to come to my clinic and for me to see you to evaluate neglect and screen.
Nobody can argue with that. Having said that, we're probably going to need to partner really closely with the adult protective service groups in order to help them help us. Right.
Agreed.
Hi, I'm another Mark, so I'll follow Mark Lax. I'm Mark Yaffe. I'm a family physician from McGill University in Montreal. Some of the research that I do is in family caregiving, and one of the things that frustrated me with the caregivers in my practice was that in many cases they refused the bright ideas and bright suggestions that I was giving them, and so I decided to do some research on it and learn a little bit about what determines caregiver readiness to accept or reject my recommendations, rightly or wrongly. That has implications as well, though, for the patient and the patient's right to self-neglect. And I haven't heard very much about the right of self-determination as far as an individual's right to self-neglect. And I wonder if the panel might want to comment on that.
I did throw up for just a second the National APS Code of Ethics, which is completely based on self-determination. I mean, most of it is around the adults' right to make their own decisions, to, say no thank you, to, refuse everything. But the question always comes down to, can they make those decisions? And then, as was just said, who decides that? How do they decide that? That's really the pivotal point, I think, we're talking about. But clearly the ethics is that an adult has a right to make their own decisions. And APS gets criticized a lot because we walk away from self-neglect cases who refuse services, and then the community's up in arms. I called them, they didn't do anything.
Thank you. I must have missed your slides sitting in the corner there.
Sorry.
So
It's only up there for a second.
this is Ron Acherno. Mark, a real quick point. Actually, neglect in our community thing was, if you look at individual, that was the highest. So this was an identified need and no one to do it. But that was with cognitively intact individuals. And so if it's the highest among cognitively intact individuals, then what you're saying has to be like amplified times 10. for the non-intact, and we're not going to get that with random digit dial methodology. You're absolutely right. One thing, though, that might sort of pull these things together is in the right to die literature and in the ethics of the right to die, we generally look at the person's level of depression and hopelessness to say, well, if this person understands things and not really depressed, they're making a logical decision, they want to withdraw care, and we let them do that. What I had tried to put up before in terms of outcomes, the so what question with a focus on mental health, that's again an issue here. If a person is very depressed, which is an eminently treatable condition, though in the past not so much so thought so in older adults, and we know that that's wrong, it is eminently treatable. If they are depressed, they're far more likely, as per the definitions of depression, to self-neglect. And you do get into that vicious circle, but we don't know the extent of depression in these mistreated adults. And the reason we need to know is that one type of mistreatment may well lead to another. So if you're depressed because someone has emotionally mistreated you over the years, then you also become at significantly higher risk for neglect and then self-neglect. I think we don't know because we don't know how the outcomes of mistreatment are. So I think depression might be an extraordinarily relevant key to neglect. I mean, it makes sense. And it might also be that key to the cross-abuse sort of synergy. But we'll need to have that so what study to know what the outcomes are of each form of abuse.
Depression both in the victim and in the perpetrator.
I would just like to add a complicating factor here. While, sorry. I just said because there aren't any. Okay. When I was directing the WHO program on aging and health, we did a survey, and the vast majority of countries are not as lucky as the United States in terms of the legal systems and the legal frameworks. You may think that you still have problems in regard to this, and I hope that tomorrow in the subgroup we'll discuss this. All the effort to detect self-neglect and neglect goes entirely through the sink if you don't have the mechanisms to intervene. And very briefly, I will describe a very traumatic case in the apartment building where I live in Rio de Janeiro. The doorman, and I was talking before that they were identified in this qualitative research as the best friends that older people have in the community. The doorman had for 3 years reported self-neglect by a woman that was living on her own with dementia, and there was no relative whatsoever. Eventually, after 3 years of effort, a second cousin that had not seen or visited for 8 years, living in another city, was identified, and this woman had to be brought in order to intervene, and eventually this woman was taken to residential care. It was very traumatic for this woman, who had very little to do with this older woman. And if we don't have the legal systems, the frameworks to intervene, all the effort to detect self-neglect and neglect is effortless, because we are not really going to be able to intervene effectively.
Can I add one quick thing? Nobody's brought up the Aging Network as identifying neglect cases. They see a lot of older people, they see a lot of family caregivers, they deliver home-delivered meals, they do in-home case assessments for services, and they really should be screening for abuse, neglect, and exploitation routinely.
Hi, I'm Jill Livingston here. I wanted to mention two things. One thing in response to Mark is that clinically the worst self-neglect people that I have seen have been seen really too late. A woman who had only eaten crisps for 4 years and had a hemoglobin of about 4, things like that. And a man who'd been looking after his paranoid wife for years and not known services and began to dement. And they had nothing. They were lying on the ground in a blanket with no food. And I think the only way we can identify these very worst self-neglect before there is the almost end of life stage, and find out about prevalence and attributes and how to detect them, is that when you do your telephone survey, the people who don't answer the phones are the ones that you go round to, because they're the most needy. It's a bit like in clinics, that the ones who don't come to see us, we go to see them, because they're probably iller than the ones who do come to see us. So that's one thing. But the other thing, I looked at your ethical considerations, and I was completely stunned that in America, I had no idea that people have competence until a court says that they're incompetent. I think that's absolutely unbelievable. I mean, you should. How do you have any money left to do anything once you've had to go to court and go to the judge to declare them incompetent? Absolutely amazing waste of resources. I think that the 99% Americans in this room should be campaigning for a change in the law, so that it's quite clear about how you declare somebody incompetent. And when their doctor sees them and goes through them, or their social worker and goes, because that's what we have with Mental Capacity Act in Britain, and the decision maker that can declare them incapacitated for this particular decision, because capacity is situation specific. I don't know if you have to go to court every time you look at another one, but I cannot believe that you can manage to maintain a country with having to go to court every time you want to do it.
And Gil, we will certainly touch up on that point during our next panel. This young lady has been waiting for some time. I feel awful. That'll be our last question, perhaps a brief one.
Thank you. Linda Kincaid with the Congress of California Seniors. In California, APS and law enforcement typically will not respond to abuse and neglect of elders that are under conservatorship. Is there any training currently in place or any training planned that would protect this population of elders under conservatorship?
We don't have any training for that. I don't know how common that is across the country. I think there are many APS programs that go out to people under guardianship. And in Illinois, we had a whole process for where we thought the guardian was abusive or neglectful. We had a process to go through on how to change guardians. So that may be unique to California. I'm not sure.
Thank you.